This episode of Common Health is brought to you by Reg Lantern. Reg Lantern is a straightforward and easily understandable software platform built to assist community health centers in staying compliant so they can focus on serving their patients rather than paperwork. For health centers that are serious about achieving, managing, and maintaining compliance, Reg Lantern provides a comprehensive approach and is an affordable and valuable solution. Reg Lantern can help your health center. Contact them today at reglantern.com. That's REG, as in regulations, lantern.com. For special discounts, mention that you heard about Reg Lantern on the Common Health podcast.
Well, hello, listeners, and I'm happy to be back to share with you another great show. It's been some time since you have actually heard from me. I know we've had some other guest hosts for some other shows, but I'm really glad that I was able to come back and host this show, because today we are going to talk about a topic that's very near and dear to me, and it's something that I've been wanting to bring to you all for some time now. I am pleased to introduce to you two very special individuals, I have to say. One I just met, but another one I've known for a while. First, I want to introduce you to Dr. Wally Smith. He is the director over the Florence Neal Cooper Smith Professor of Sickle Cell Disease at Virginia Commonwealth University here in the state of Virginia. Dr. Smith is a widely published individual on the topic of sickle cell pain management, crisis prevention protocols, and sickle cell program design. Dr. Smith is truly, and hear me, audience, he's truly a treasure among those who suffer with what I can tell you from personal experience is a cruel disease. Why am I saying this is a personal experience, listeners? Because the other guest we have, I happen to be related to, who has sickle cell, and he is my husband, Damian Jackson. And so Damian is a litigation partner in the law firm of Reilly, McDevitt, and Henrich. Damian has a great career and a wonderful wife, I must say, listeners, including his recent selection as one of the top African-American influences in the city of Philadelphia, Pennsylvania. So Dr. Smith and Damian, thank you for joining me today.
Thank you for having me.
And thank you for having me, since I come way behind your husband.
Oh, right. Okay. So, Dr. Smith, you and I have had a chance to talk about your career and the great things you're doing here in the state of Virginia as it pertains to sickle cell. But the one thing I want to talk about just real briefly before we get into the topic of sickle cell is I want to hear about, I understand you're now a published author. And so can you please, just for a few minutes, just take a moment and can you tell the listeners about this new book of yours?
Yes, Tracy. Pain is the most often cited and the most egregious symptom that patients with sickle cell disease, we call them warriors, suffer. Pain is the reason why people with the disease know they have it. Pain is the most hated symptom by medical doctors treating patients with sickle cell disease. You can't measure it. You can't doubt it successfully. You can't prove it. And pain is what doctors and patients with sickle cell disease fall out about the most. The guidelines are pitiful. The research undergirding the guidelines is new, not really mature. And pain in America is one of the most controversial topics. It's understudied widely. So we wrote a book about managing pain in sickle cell disease. It takes 26 cases from the cradle to the grave and tells doctors what to do with those cases, because that's what they want to know. So the subtitle of the book is, What Do I Do Now?
Wow.
And so these cases talk about school and work and emergency and home and hospital, and what to do when doctors disagree, and can I smoke marijuana? I'm depressed. I'm suicidal. They don't believe me. It addresses all of those topics and tries to level the playing field. We view it as something that patients could use as advocacy if they bought the book. But more importantly, doctors who don't know how to care for pain in sickle cell disease, and that's most doctors, could use as a manual to help them navigate this vast area of understanding pain. We know more about the mechanisms of pain in sickle cell disease than we ever have, but we're not applying the treatments that come with understanding those mechanisms in any real way so far. So we're not using things like massage and cognitive behavioral therapy and non-opioid pharmacologic management. We're not using that the way that we should. And this book helps people understand why and how to do that. And it also helps them understand where the gaps are. Plenty of gaps. So this is not a textbook. This is a manual. But it is also not something for the faint of heart. And to understand all this, you really have to read hard. And in some of the references that we give, you might even have to go to some of those references. What we hope it will do is level the playing field so that the pain of sickle cell disease is taken seriously, and so that people who treat patients with sickle cell disease won't feel so left alone, frustrated, abandoned, negative about this disease.
Thank you for that. You know, you talk about having this book be used through various avenues, right? For those who are afflicted with sickle cell, for those who are treating sickle cell, for those like myself who would advocate for a cure, as well as other stakeholders. And so what I want to do for our listeners is we'll start with you, Dr. Smith. Tell us what sickle cell disease is and the trait.
Yeah.
And then what we'll do is we'll go over to Damian, who has sickle cell disease, and ask him some questions. So what is the trait, the sickle cell trait, and then the disease?
The sickle cell trait is a survival advantage in Sub-Saharan Africa, where it's one of the 5 places where this mutation, it's a genetic mutation, spontaneously arose. People with the sickle cell trait have a survival advantage against malaria. So the trait arose in 5 different locations, all of which were endemic to malaria, and it proliferated as people with the trait survived over people exposed to malaria without the trait. When 2 people with the trait have a child, this is a recessive trait if you remember your genetics. So when 2 people with the trait have a child, there's a 1 in 4 chance that that child will get the trait from each parent and end up with SS, homozygous sickle cell disease, which is a killer. It is basically associated with anemia, with the cells being destroyed more easily because they're funny shaped. They are shaped like a gardener's sickle, but nobody knows what the gardener's sickle is anymore. So might as well call it crescent disease because it's like the crescent moon. But it's not the only shape that these cells take. But your red cells look funny. They don't go through the vessels the way they should. And they also aggravate the white cells, the platelets, and all these sticky substances inside the vessel. So you get blood vessels vaso-occluding everywhere in the entire body as early as 6 months of age. You can have strokes, you can have organ failure, you can have infections. You can die from organ failure even in childhood. And if you make it to adulthood, you're anemic, you're in pain. The pain is very, very irritating. It is sudden in onset, usually as a child, and then later in life, it becomes more constant. Oster said to know syphilis is to know medicine, and I have now borrowed that term, and to say to know sickle cell disease is to know medicine. There's no part of your body that this disease does not affect. Needless to say, because of where the genetics arose, you can trace now where the disease is most prevalent. And it is most prevalent in Sub-Saharan Africa, in the Middle East, in Saudi Arabia, in India. And in the United States, we see African Americans, 1 of 12 African Americans having sickle cell trait, and about 1 in 360 African Americans being born with sickle cell disease.
Wow. Damian, can you share with the listeners your life living with sickle cell?
Okay. I guess from my earliest memories, I always knew, I guess, being drilled into my head from my parents that, okay, as far as physicality, I was different. Okay. I had to make sure that I ate right, that I got enough rest, and that if I became sick, that I needed to tell them immediately so that those things could be addressed and they could not hopefully prevent them from becoming worse situations. I can remember at, I don't know, the youngest ages, just being in incredible pain and being taken to the emergency room and being given medication that basically didn't really address the pain, but, would knock me out. And I would just be drowsy. And once I woke up, I was still in pain. Being given IV medication for a period of time in the emergency room, and then being sent home, and my parents being told, okay, well, put hot compresses on them and put them on a heating pad. I can remember an episode, we were in the hospital and the doctor told my mom that, oh, these are just growing pains, things of that nature. As I got older, and got involved with the actual program at Children's Hospital here in Philadelphia, they had a program for children with sickle cell, and they were more in tune to, the things and the modalities that needed to be done. But again, it was still a very similar structure as to make sure that, you eat right, when you can exercise, make sure that you don't get cold. Don't let your extremities get cold. If you pick up a cold or a flu, make sure you address it and don't ignore it. And just, having to not be able to necessarily do everything that, maybe other kids could do because of the sickle cell, just being mindful in the back of your mind at any point in time, that little pain that you might have might turn into something. That might not just be a little pain. And I can remember, times playing outside and getting a little pain, and then that night being in full crisis, with no rhyme or reason. I can remember times coming home from school, having a fine day at school, no problems, no issues, and then waking up in the middle of the night and just painful crisis and having to be rushed, back and forth to the emergency room with really no rhyme or reason, being checked out and then being given, I forget what the medications were back then. I think they were called Duravons or something like that, for pain, and then being out from school because of the pain crisis. luckily for me, as I got older and once I was about in high school, they stopped for me for the most part. But still, I had to go to the doctor more regularly, getting, my blood check, my hemoglobin check, things of that nature. But then I started becoming very susceptible to getting pneumonia. So it seemed like almost every year when I would catch a cold, it would turn into pneumonia, which would land me into the hospital for a whole nother series of, you know, sometimes blood transfusions. Sometimes that pneumonia would turn into a painful crisis. And again, missing time from school and friends and things of that nature. And it was just that continuous cycle throughout my lifetime. And I can tell you that I have probably had pain, and as the doctor said, in every part of my body, from my head to my toe at different points of times. The sickle cell has manifested itself in those ways. I've been fortunate that I don't get crisis as often as many others do. I think my crisis last year was the first one I had had in approximately 20 years. But that's just fortunate for me. I have been in groups and been part of groups where I have advocated for some of these people. I have good friends who had sickle cell, and they would go into the emergency room and they would, treat them as if they were, in fact, drug seekers. And I was part of an advocacy group that would call these hospitals and, talk to the risk managers and tell them and insist that, hey, look, check this person's hemoglobin, check their medical records. Okay, this might not be their hospital of choice, but this was the closest one for them. And they need to be seen and be treated as such. And they're not drug seekers and have to go up the whole line. I've had to do that for myself on a number of occasions because people don't believe that you are in pain or that you need the required medications that you do. I mean, once you get to be, I'm 58 years old. I've been dealing with this my whole life. So at a certain point, I know if I'm in crisis, this is what I need to get pain relief. And sometimes you have to argue back and forth with the doctors and medical staff to say, look, you might be the doctor, but this is what I need. Okay. I know 10 of morphine might sound high to you for for somebody who you've never met, but that's what I need. You can check my records and that's what I normally get. And you have to, unfortunately, fight a lot of times because, as the doctor said, people don't know. They don't understand. And since there are no objective medical testing for pain, each person has to be treated individually.
I want to pivot off of what Mr. Jackson said about the 10 of morphine. That scares the average doctor because it's more than a person who's never seen morphine before would normally take. But I want to distinguish tolerance, which is I need more than I usually would get because my body is immune to it, from addiction, which is I'm asking for it to get a high or to misuse it. A lot of sickle cell patients have had morphine all their lives and their body is immune to it. That's tolerance. So they do need higher doses. That does scare the doctor. And if you don't know anything about sickle cell disease and you don't understand that, you will confuse that with addiction. Not so. And that's one of the things we talk about in the book.
So, Dr. Smith, that being said, let's just kind of get the elephant out of the room. Let's just quickly talk about addiction, okay? Could a sickle cell patient, given the fact that their bodies tend to be immune to the high amount, large volume of morphine that goes into their system, though, could it be a situation where they could get addicted, though?
The answer is yes. Is it usually that situation? The answer is no. So let me explain 3 concepts. I've explained 2 of them already. Tolerance is when you need more than you normally would. Physical dependence is when you've been taking the medicine every day and you stop and your body has withdrawal. Some people think that's the same as addiction. No, that's a physical phenomenon that happens if you take the appropriate amount of narcotics every day because you have pain every day and your doctor gave it to you every day. And then you suddenly stop and your body goes, I want it back. And you have withdrawal, and everybody understands what withdrawal is because we associate that with addicts. But withdrawal can occur in somebody who's not an addict. Addiction means I'm using it for reasons other than pain. I'm using it in more and more quantities. I'm stealing in order to get it. It's impairing my function. I have people who take narcotics every day and work and drive and manage and are not addicted, but they're both tolerant and physically dependent. So we need to stop demonizing the use of opioids in this country the way we have. I'm going to talk about another elephant in the room, and that's the opioid epidemic. Sickle cell was not a part of the opioid epidemic. We have the data that shows that no sickle cell patient in the last 10 or 12 years has died in a hospital from an overdose of opioids. That the people who are more likely to be opioid misusers are people with back pain, people with heart disease, people with diabetes, people with headaches and migraines, not people with sickle cell disease. The published data is out there. So those who worry that those sickle cell patients, those people, are going to become addicted, they're just wrong. They're not the ones. So we need to understand that, yes, anybody, including a sickle cell patient, can become an addict. But I will tell you, I have way more trouble with underuse of opioids than I have with overuse or misuse.
And so, it's interesting, and I want to make sure we go back to the topic of how these crises that sickle cell patients go through, and what is the mode of treatment to taking care of that pain is
yes,
narcotics.
Yes.
But that being said, I will say, as a spouse of someone afflicted with sickle cell, when Damian had his crisis a couple of years ago, man, he was pumping that morphine. I mean, he was hitting that button when he was in the hospital.
Yes.
And to me, having been in healthcare most of my career, I'm watching this.
Yes.
And for me, there's this sense of just a little bit of a red flag kind of goes up. But I will tell you, when he got home, it all changed. Like I don't think the last time I've seen him take a narcotic pill, right? It was very easy for him to stop using it once the crisis has.
Well, you're hitting on two major scientific points that I want to emphasize. The first one, Damian said a few minutes ago. He said, when I go into a crisis and I'm in the hospital, they give me medicine. It doesn't really take the pain away. It just puts me to sleep, and I don't care about it for a while. And when I wake up, it's still there.
Right.
What he's defining is what we call palliative care. We do that for cancer patients, and we don't think anything about it.
Right.
Why do we have an attitude when we do palliative care for sickle cell patients? They deserve the same. Maybe it isn't taking the cause of the pain away. Maybe all it's doing is giving them some relief so they can sleep. Most of them have been up for days at a time by the time they get to the hospital. And maybe the pain has to go away from the fluids that you're giving, or maybe There's some other medication to abort the crisis. We're still working on those medications to actually abort a crisis. But the major reason why you're taking painkillers is to get some relief from a symptom, not to make the cause of the symptom go away. That's the first point. The second point I wanted to make is, how long does it take for you to become addicted? How many days in a row do you need to be on these medicines? And the answer is 30 or more. So for the length of time that you're in a crisis, usually a week or two, if you don't take the medicine more than 14, 21 days in a row and you stop, you're not going to have withdrawal, and you're not going to be, quote, addicted. And I'm not using that word in the appropriate way anymore, because I just told you that's physical dependence. You're not going to be physically dependent. People miss that. They think that the high dose of opioids is enough to get you addicted. That's just not right. You have to be on it for long enough that your body says, hey, I'm used to this now. Takes a long time.
So why is it, Dr. Smith, that Damian and other sickle cell patients at a young age experience crisis like a lot of times, right? They go through a crisis, but here it is. He hadn't had a crisis in 20 years.
Well, I'm going to throw it back at Damian's lap because he's an experienced patient. Tell us your observations, Damian. What are you doing differently now?
I guess now that I'm older and wiser, I do things more carefully. Everything that the doctor tells you to do: eat right, sleep right, get exercise, rest, take care of your mental health. I also was at one point regularly getting massages and just really trying to take care of your overall health, which I can't say that I did when I was a younger kid, because, you want to do things that young kids do: hang out, stay up late, eat junk food, things that don't necessarily are good for your body.
And there you have it. So we have 3 medicines available to stop the sickling process, but we really rely on patients to prevent the sickling process on their own. He has just said you need, somewhere between 96 and 128 ounces of water per day. You need to avoid extremes of hot. Biologically, that will shift the oxygen saturation curve, make you more likely to go into a crisis. You need to avoid extremes of cold. That will shift the hemoglobin oxygen saturation curve, make you go into a crisis. You need to dress warmly when you go outside so as to not shift that curve. You need to eat, because folic acid builds new red blood cells, and you're destroying your red blood cells all the time. You need to take a folic acid supplement on top of eating every day for the rest of your life. You need to get regular rest. Rest replenishes your oxygen, your muscles. Your brain requires rest in order to function properly. You need to exercise carefully so as to not overexert yourself and become anaerobic in your metabolism, which will produce a crisis. Damian just answered your question. So this is what we explain to patients, and it is difficult to live that way. I'd be a fool if I thought everybody was going to do that, but I at least have to tell patients to do it. And when they learn to do it and learn that it reaps a benefit of not getting sick, they can start doing it on their own, and I don't have to tell them anymore.
So how do we help our providers? Especially, to me, Again, listeners, reminding you that this podcast, this show is brought to you and supported by the Virginia Community Healthcare Association that supports federally qualified health centers in the state of Virginia. And there are 1,600 FQHCs, we call them, in this country. And we are mostly primary care providers. We mostly provide primary care, Dr. Smith and Damian. And how do we help our providers? Because I think that primary care could play a really important role in helping to manage sickle cell patients. When you look at where FQHCs are located, they're located in communities that individuals have a challenge in accessing good healthcare services. It could be a number of reasons why they have those challenges. We tend to be in very high rural areas. How can we help our safety net providers, our primary care providers, do better with managing sickle cell?
Well, that is a wonderful question. I welcome it. We are on a campaign to do exactly that, Tracy. We are hosting webinars, that we call them echoes, every month to train the providers you just talked about how to manage sickle cell disease. We present a case, and then we do a 30-minute mini lecture on some area of expertise in sickle cell disease, experts from around the globe. We also run conferences. One of them is called Sickle Cell Care Coordination to Achieve Patient Empowerment. It's held here in Richmond every spring. We've been doing it for 6 years. We're developing a online training course. It's really designed for nurses and social workers and community health workers, but a physician wanting to get the basics of sickle cell disease could even take that course and get some training that way. It's coming out of the Scape brand, so when it's not online yet, but when it goes online, it'll be the Scape brand. We wrote this book partly to fulfill that mission. And then we have been going around the state under a grant from the federal government to actually recruit primary care doctors to care for sickle cell disease. Sometimes they are guilty of the same biases that other doctors are guilty of. I don't want no drug addicts in my clinic.
Right.
I understand you don't want any drug addicts in your clinic. And I understand you probably don't even want to prescribe opioids ever if you can get away with it. But would you not mind doing it for the people who are, at least like Damian, responsible enough to care for themselves? They're not the most difficult patients to manage. They get sick once, maybe twice a year, and they need maintenance, and they need you to say in their ear, hey, are you getting your rest? Are you taking your fluids? Are you taking your folic acid? Do you take hydroxyurea? That's one of those 3 drugs I was talking about that's available. It's easy to prescribe that drug. Are you getting blood checks? Do you need to be transfused? Have you been doing preventive care? You get your flu shot, your pneumonia shot. These are things that are part of the fabric of primary care. I'm a primary care doctor, Tracy. I'm not a hematologist. I got into this because I saw that primary care could take care of sickle cell patients. Mm. So I really know for a fact that you don't have to be a blood specialist to care for sickle cell disease. Yes, it's good to have an expert nearby, but you can do most of the care as a primary care doctor.
I'm wondering if there's an opportunity. We are exploring here in Virginia with the FQHCs the idea of doing e-consults with the primary care providers and individuals like yourself, Dr. Smith.
Yes.
Right? So that those subject matter experts, we'll call them for the sake of explaining for our listeners, could be on tap, right? If that
Absolutely.
primary care provider is got this patient, knows they have sickle cell, does not have the experience, they then could reach out to you through an e-consult
Absolutely.
and be available to that provider. Is that something that you could see really?
We're way ahead of you. We already have a WhatsApp group. It's active. It's nationally available. People can join this WhatsApp group. It's called the Sickle Cell Adult Provider Network. You present your case. You get an immediate response from the experts on the network. You have to have the patient be, withhold the name, obviously, of the patient. And when you get an answer, you're not getting a formal medical consult that somebody can bill for. What you're getting is an opinion. Well,
Right.
I don't see your case. I don't have your case, and I can't take legal responsibility for the opinion I'm about to render. But in cases like yours, this is what I would do. We have that up and going already.
Wow. Before we get to, before we close out today, I have questions for each of you. First, Dr. Smith, we talked about managing in most of our time together, managing those who have sickle cell. But is there a cure? Is there a cure to wipe out this disease?
We have good treatments, and we have 4 available cures in the hoping. Let me explain what I mean by that. We reverse, either with your cells or with donated cells, we reverse the sickling phenomenon with the hope that it will stay reversed forever. So the bone marrow transplantation, there's 2 different ways of doing it. You can get a relative that has a 4 antigen match, or you can get somebody that you don't know. That's what we call a half match, a 2 antigen out of 4 match. Both of those have been around for a couple of decades, and we've done over 2,000 patients. And I'm going to hesitantly use the word cure. We're watching them. You need to watch them for 10 to 15 years to make sure nothing goes wrong. There's a concern that they might get cancer after the treatment. There's a concern that they might get graft versus host disease after the treatment. There's a concern that something might go wrong and the treatment fail. But we are hopeful that those 2,000 individuals will go on to live great lives. And they're stuck with the damage that was done prior to their procedure. Some of them, unfortunately, are stuck with long-term pain that developed prior to the procedure. So when you use the word cure, you didn't take away all the damage that was already done. And then we have these 2 gene therapies. One is adding a gene that corrects the sickle cell problem. The second one is substituting a gene that corrects the sickle cell problem. Very expensive, hard to get yourself in line for those. Not every center does it. VCU is one of the centers that does it. We have those available, and the line is lengthening because there's a lot of insurance hurdles and there's a lot of screening that must be done, and you got to get chemotherapy and transfusions just to prepare yourself to get those procedures done. So that was a long yes with a lot of qualifiers to the question.
And Damian, we'll end with you. What's your hope? What's your hope for yourself and other people with sickle cell out in this world?
I guess my hope, and I guess we haven't really spoke about it extensively here, but my hope is that a person with sickle cell who is in crisis can go into any emergency room at a qualified, hospital and get treated well. I think not only is it the stigma of the sickle cell itself not being studied very much in medical schools throughout the country, but the elephant in the room, people who have this disease for the most part are Black. And they go into these hospitals where the providers are not Black. And the first thing that they think of is that there's a distrust there, or that for some reason, and I've read the studies when I was, doing research at one point that, Black people, they can take pain, they can tolerate pain better. So they don't need as much, pain medication and things of that nature. So we only need to treat them with this, or they're not smart enough to know that, 10 of morphine is enough, or that's too much. Just, not giving these people who are patients, who are in need, the benefit of the doubt that they know what they're talking about. They're living with the disease, and giving them the same quality of care that they would give anybody else. That's all I would ask. I mean, it would be great to get a cure. It would be great for everybody to, be pain-free, but I think that's a utopia that I won't see in my lifetime. So until that time, to give everybody a good quality of care so that they can get through these episodes.
Well, I'd like to thank you both for joining us today. And listeners, as I always try and say to you and promise you, is that our commitment to you is to bring the best real stories that you don't hear every day in the news, but they're real. They're people who are going through these situations, and there are people out there who are trying to make a way, like Dr. Smith. I want to thank my husband, Damian, for joining us. Damian, I know you're a very private person, but you sharing your experience with our listeners really makes a difference. So thank you for that. And Dr. Smith, you're my jewel. And so listeners, I told Dr. Smith when I initially met him that poor thing I've got his number now. So, I can give him a call, or I can just show up at VCU Medical Center and just knock on his door. So I feel sorry for him because it'll get to a point where he's like, look, Tracy, I got a job to do. I can't keep, talking with you about this, but that being said, I hope listeners that you got to hear and really feel what I've been talking about when it comes to a disease such as sickle cell. Listeners, I want to say thank you again for listening and supporting Common Health, that's brought to you by the Virginia Community Healthcare Association. If you want to get Dr. Smith's book and learn more about Dr. Smith, there will be a link in our Common Health website, as well as the website of the association at vcha.org. You can also get access to this podcast where you get most of your podcasts from, as well as going to vcha.org. Again, gentlemen, thank you for your time. Thank you for your time.
If you enjoyed this episode and you'd like to help support Common Health, we encourage you to hit the subscribe button, share it with others on social media, leave a rating and review, or visit our website at www.vcha.org.